in August 2017, an estimated number of 671,000 Rohingya refugees fled from violence in the Rakhine state of Myanmar, seeking protection and safety in Bangladesh in what is to this day the biggest movement of refugees into Cox's Bazar, the country's southernmost district. This unprecedented influx triggered the onset of a major humanitarian crisis that rapidly led to the establishment of the largest refugee settlement in the world. Today, 890,000 Rohingya refugees live in 34 densely populated camps where overcrowded and poor living conditions contribute to the high risk for the spread of infectious diseases. This complex humanitarian situation became more critical after the onset of the COVID-19 global pandemic in 2020.
The massive influx of the Rohingya refugees into Bangladesh in 2017 posed a great challenge on all levels, but concerns related to health assistance were particularly critical. Most of the Rohingya population fleeing to Bangladesh were women and children in vulnerable situations who walked for days through challenging mountain paths to reach the refugee camps in Cox's Bazar. With no previous history of vaccination, Rohingya people arrived in Cox's Bazar exhausted, hungry and sick, and with very low protection against vaccine-preventable diseases. Additionally, mental health and psychosocial support needs are known to increase significantly among emergency-affected and migrant population. In the absence of a legal framework and in the urgency to meet the health needs of the displaced population, a health coordination structure was rapidly established by WHO under the leadership of the Ministry of Health of Bangladesh to guide the response of an extensive network of humanitarian actors, including United Nations agencies, international and national organizations in the early phases of the response. The Rohingya emergency response implemented by the government and humanitarian partners soon addressed the health needs of the Bangladeshi population living in the vicinity of the camps as well. Therefore, to leave no one behind and progressively realize the vision of universal health coverage.
4 years later, the emergency has moved into a protracted phase. While more than 80 humanitarian partners continue to form the health sector, ensuring health service provision and well-being of the 860,000 Rohingya refugees and 472,000 host population in the vicinity of the camps under the guidance of the government of Bangladesh.
Responding to health needs of vulnerable population in Cox's Bazar requires collective and joint action among the wide range of humanitarian actors involved in the Rohingya emergency response since 2017. Government authorities have worked together with over 80 health partners to ensure access to essential health services and respond to the critical health needs of the refugees. Soon after the influx of government of Bangladesh reviewed the policy of routine immunization and approved the immunization schedule for forcibly displaced Myanmar nationals, which became into effect in June 2018. In addition to various mass vaccination campaigns against polio, measles, rubella, diphtheria, which are implemented to protect the Rohingya community. Today, a total of 175 partners-led health centers and government authority facilities offer a wide range of essential health services in the refugee camps, including routine immunization, sexual and reproductive health, mental health, and psychosocial support.
In 2020, the impact of the pandemic was expected to vastly overwhelm the capacity of the existing health services in Cox's Bazar, compromising important health outcomes achieved over the 4 years of the humanitarian response. As the pandemic started to evolve globally, concerns about the impact in the Rohingya refugee camps were increasing among government and partners.
আরাতি যেতম মাদে করোনাই বলি হেসং ফুন্নি আরাতি বেশাবে ডরাছি তো আরাতি যদি গণ গণ যেতম মাদে ছোট ছোট ভাষা মধ্যে তো জামিলা বেশ তাহলে যদি এখনো একঘর ওই তো চাইলে দিয়ে আছে বেকুলা বাড়ি বাড়ি যাই বলি আনালা বেশি বেশি ডর লাগি
Months before the first case of COVID-19 was reported in the Rohingya refugee camps on 15 May 2020, decisive preparedness and response readiness measures were put in place to slow the spread of the virus and mitigate its impact among the Cox's Bazar population, including the establishment of 14 severe acute respiratory infection isolation and treatment centers, known as SARI ITCs, to deliver effective, timely, and specialized quality care to COVID-19 patients. A multi-sectoral and pillar-based response plan for Cox's Bazar was also established in line with the WHO COVID-19 Strategic Preparedness and Response Plan framework to protect the population. In 2021, the COVID-19 response was integrated into the Joint Response Plan for the Rohingya humanitarian crisis of the government of Bangladesh and humanitarian partners.
Since the beginning of the Rohingya crisis in 2017, there were several outbreaks of other communicable diseases here in the Rohingya refugee camps, including cholera, diphtheria, and measles, highlighting the high risk and the vulnerability of this population. Due to the very difficult living conditions, including high population density, public health and social measures are very difficult to implement at similar level elsewhere. And this is why we put a strong focus on building case management capacity at a scale early on in the response. WHO, in support of the government, coordinated partners in establishing 14 isolation and treatment centers with a bed capacity of nearly 1,200 beds in and around the Rohingya refugee camps that have the capacity to provide treatment for mild, moderate, and severe cases of COVID-19, including life-saving oxygen. These treatment centers are not only accessible for the Rohingya refugees, but also for the surrounding host community, including pregnant women infected with COVID-19.
Noor Ankis was admitted in one of these isolation centers after getting diagnosed with COVID-19. As the majority of the Rohingya and Bangladeshi population living in Cox's Bazar, Noor Ankis does not have proper conditions at home to self-isolate. So these SARI ITCs become instrumental when it comes to receiving the best possible care and reducing the risk of getting her family members infected, while helping stop the community transmission. Unfortunately, the stigma and fears associated with infectious diseases, and in particular with COVID-19, still make a large portion of the population reluctant to isolate in these specialized care centers. This is where people-centered care and community engagement come in.
তো অনেক ডর লাগছে অনেক কিছু করিব না ঘরের পরিবেশে একজন হলে তো প্রতিবার পরিবেশের হনে নিয়ে যাব গনে এন হয় অনেক ডর লাগছে তারপরে হে রাহুয়ে সান্ত্বনা দিয়ে হয়তো অনতো আরেকজন হে না পারা ফান এর কিছু না করিব অনতো আরেকজন না পারা ফান দূরে রাখি ওষুধ খাবার তোমরা সান্ত্বনা দিয়ে রাখিব আর মাঝে কল করে দিত মাঝে কল করি হয়তো তোমার করোনা ডাক্তার আনি যাব দে শান্তি করে রাখিব এটা হনে কিছু না করিব হেন কয় মাঝে করি হয়তো হনে সুবিধা করলে আমাকে কল করো হেন কয় আরে এরা ফাটা দিয়ে গাড়ি তুলি দিয়ে ফাটা দিয়ে এরিয়া চিকিৎসা দেখি আর তো অনেক ভালো লাগে অনেক চিকিৎসা ভালো এরিয়ারই তারপর আমি সুস্থ হয়ে গেছি আমার তো হাঁস আসিল হাঁস ভালো হয়ে গেছে জ্বর উঠতো জ্বরও ভালো হয়ে গেছে আমার বুকমা ব্যথা আসিল ব্যথা ভালো হয়ে গেছে এরিয়ার আপাতারা অনেক ভালো লাগছে আমি অনেক সুস্থ আছি তারপরে এরিয়া হাওয়া দাওয়া অনেক ভালো এরিয়ার আপাতারা ভালো লাগে পরিবেশে বেকুন ভালো লাগে এখন কোন তান্দের মানুষ তো অবলা করতে আসজন নিগে কইতো আর বাপে আরে বড়ানি অনেক তুই হেরেকার ডাক্তার নাকি তো তাই না তো আরো অনেক বই করছো তারপরে এর মতো শীর্ষ ভালো দেখি এত সুস্থ হয়ে গেল
Since the beginning of the pandemic, over 3,000 COVID-19 cases have been registered in the Rohingya refugee camps. All SARI ITCs are in line with the WHO Infection Prevention and Control (IPC) standards for an isolation and treatment center to ensure patient and healthcare worker safety. The design of patient and staff flow of all ITCs is based on the identification of red and green zone areas, which entail different levels of personal protective equipment, PPE, to be worn by staff. PPE items are widely distributed among clinical and non-clinical staff working in these facilities, and regular supportive supervision visits are conducted by WHO IPC specialists to constantly equip healthcare workers with preventive strategies against further spread of COVID-19. Each and every person involved in the COVID-19 response in these isolation and treatment centers have been trained through WHO to ensure optimal treatment and reduce the risk of exposure to COVID-19 among healthcare workers and patients. Dedicated IPC professionals have been designated in every center, leading to the creation of a model IPC network, which is currently being replicated at district level.
In close collaboration with the government, WHO provided operational coordination and technical support for partners establishing those treatment centers. This included technical advice on site selection, layout and design of the treatment facilities, equipment, supplies and staffing, but also case management, infection prevention and control, and healthcare waste management. A referral pathway was established for those patients requiring higher level care to the intensive care unit at the district hospital.
People-centered care is a key pillar of the SARI ITC's success. Healthcare professionals work closely with the communities and devise several engagement mechanisms to increase the trust in these facilities and reduce the stigma and fears associated with epidemic diseases. In collaboration with the Risk Communication and Community Engagement Working Group, WHO and key partners have been engaging communities, health partners, and stakeholders to create awareness among the population about risk factors and protective measures for COVID-19 and dispel rumors and misconceptions.
আমার নাম সালমা ICSW হিসেবে গণস্বাস্থ্য কেন্দ্রের মাঝে প্রায় 3 বছর পর্যন্ত হাজ করি তো আর হাসল দিয়ে কমিউনিটির মানুষরা যাইরে বালা হালাপ সম্পর্কে সাহায্যতা করেন তারপরে আর কোভিড লয়ের বেশি হাজ করি কমিউনিটির মানুষের লয়ের কোভিড যদি পজিটিভ পাদ হয় কোভিডর হদিন আলামত আছে এই আলামত তিনি তার আর বুঝায় যদি তার আর এলা কোনো বিয়ারেমা ফায়দ হয় তারপরে আর রেফার দিয়ে হারার হাসপাতালত কোভিড টেস্ট করিবালা পাঠায় টেস্ট করিবার পরে যদি কি তার রাতে কোনো 3 দিন পর্যন্ত টেস্ট করিবার পরে 3 দিন পর্যন্ত তার আর অপেক্ষা করা পরে যদি তার রাতে পজিটিভ আয় হয় তারপরে আর যায়রে তার আর গিয়া করি কাউন্সিলিং করিরে বুঝাই যদি নজাদ হয় বুঝা পরে দে যদি ইতার যাই গিয়া কোয়ারেন্টাইনত যাইবলা যদি কি রাজি হয় আর তেদুম বুঝানো পরে কাউন্সিলিং করানো পরে
Salma is part of a skilled team of over 1,400 community health workers, led by UNHCR and World Concern and MEDAIR, of which 60% are Rohingya refugees, who conducts more than 140,000 households visits per week, sharing important information on COVID-19 prevention to targeted members of the family through door-to-door visits. They are trusted members of their community, and their mission is to share correct, up-to-date, and appropriate health information about COVID-19, including community-based surveillance and information on home-based care and relevant non-pharmacological interventions to be practiced by individuals and society against common health hazards. CHW also counsel on testing, quarantine, and patient referral to isolation facilities, representing best practice in risk communicators and community engagement.
আরা কমিউনিটিতে যাই দিই তারা মানে আর মনে করে দা আরা মানে ডাক্তার মনে করে তারা আরারে আসলে আরা কোনো ডাক্তার নয় তা আরাই তারা আরে যাইরে মানে ওই তারা আরাম বিয়ারাম অসুখ বিসুখই ন সাসিতা করি তো এই তারা যদি কি হনো বিয়ারে মে ফায়দা হয় এডে রেফার দি ইতারা আরার লয়ের বহুত ফায়দা করি ফাইজা কারণ ইতারা তো হনো কারণ ইমার্জেন্সি কারণ অসুখ হয়ে তো আরার নম্বর থাকে ইতারা বেশিরভাগতে আরার নম্বর থাকে
community health workers have also played a significant and irreplaceable role in the COVID-19 vaccination campaign, which already vaccinated 33,386 Rohingya refugees of 55 years old and above through a successful vaccine rollout that, despite initial uncertainty and hesitancy, registered a high uptake among a population with a history of limited health-seeking behavior. Rohingya refugees were included in the National Deployment and Vaccination Plan, NDVP, by the government of Bangladesh as a target group in early February 2021, with a similar phased approach as used for the host community. Soon after, an extensive communication and engagement campaign involving key community members and religious leaders was initiated in all the camps, aiming to raise confidence, trust, and acceptance among the Rohingya refugees, leading to better uptake of the COVID-19 vaccine. While efforts to fight the pandemic continue worldwide, Bangladesh has so far successfully limited the health impact of COVID-19 in the world's largest refugee camp, while striving to sustain essential health services delivery under unforeseen circumstances. Despite the challenging and complex context in Cox's Bazar, partners and healthcare workers have joined forces in an integrated response to ensure the best clinical care of COVID-19 patients and ensure that no one is left behind.